So at this ESH meeting, I had the privilege of talking about long-term follow-up of Venetoclax trials in CLL. It's hard to believe it was almost 8 years ago at this point that we presented the very first clinical data on this drug ABT-199 that later became Venetoclax, and it was certainly obvious early on that this was a very active drug. But over the last several years, we've started to learn more about the longer-term effects of this drug, and so that's what I focused on in this session. First, in terms of safety, we did a comprehensive safety analysis of the early phase Venetoclax trials in about 350 patients, and we didn't see any later toxicities occurring, certainly during the first year of therapy and into the second year of therapy. I did highlight in the talk that this is an area where we do need to continue to gather data, but certainly no signals of long-term safety issues with this drug, even for patients on long-term therapy. Now, in terms of the longer-term efficacy data, there's been a few recent retrospective analyses that have really looked back at the early phase trial experience, particularly for those patients who have been on Venetoclax now for several years. And several key observations have been made. Across the studies, we've seen that patients who can achieve a complete remission on Venetoclax do tend to enjoy longer progression-free survival, perhaps not surprisingly. Also, the attainment of undetectable MRD, both in the marrow and in the blood, also predicts for longer response. Now, a number of genetic factors have been explored, and at least initially, we didn't think that these would necessarily have much of an impact on the efficacy of Venetoclax. So, for example, patients with aberrant TP53 high-risk disease, patients with other somatic mutations like Notch1 and SF3B1, sort of in the early analyses, these did not really impact on the response rate or depth of response. But what we have seen emerge now with longer-term follow-up is that these patients do tend to have shorter response duration, particularly those patients with deletion 17p or TP53 mutation, but even some patients with Notch1 mutation, SF3B1 mutation may have shorter durability of response. And other clinical factors have also emerged, particularly patients with bulky lymph node disease and patients who have progressed after the B-cell receptor pathway inhibitors do seem to have a shorter progression-free survival with longer-term follow-up of Venetoclax. So I think these are populations where we really need to be exploring combination-based therapies, and I think that's going to hopefully allow us to prolong these responses. And I think that remains an area of active research in the field. So also in the same session, Lindsay Roker from Memorial Sloan Kettering presented some interesting real-world data on Venetoclax-treated patients. And I think that in contrast to what we've seen with ibrutinib real-world data, the Venetoclax real-world data, at least so far, looks more similar to me as compared with the clinical trials. So with ibrutinib, we tend to see much higher discontinuation rates in community practice, some higher rates of things like atrial fibrillation, for example, leading to discontinuation. I would say in the Venetoclax experience that Dr. Roker reviewed, the AE profile of Venetoclax did look overall fairly similar in the community setting. The rates of discontinuation have also been fairly similar. They have reported on somewhat higher rates of tumor lysis syndrome in the community setting. I think there is a learning curve with Venetoclax, and the patient populations are certainly different outside of clinical trials. And so I think those two factors may contribute to that risk. And so I think when using Venetoclax in the community setting, we certainly need to be mindful of the patient's disease bulk, their renal function, and need to get them through the Venetoclax ramp-up period safely. But I think once we do that, these patients can do very well in the long term on Venetoclax therapy in the community setting.